Hello and good morning to one more lecture for hematology that is about lymphomas. And we had already done the leukemias part. And as I told you, what is the definition of lymphoma? Uh, Again, like not so, what you could say, it is not always like this that they like all the lymphomas or leukemias they follow the same definition, but more or less you can say lymphomas are the malignant cells which arise in the lymph nodes and lymphoid tissues, and then they may spread anywhere like bone and bone marrow. And as I told you, that it is not about the location where these malignant cells are found, but they are classified according to the characteristic of the cells, how they look like, what they contain, immunophenotyping, cytogenetics, molecular changes, and all this stuff, right? But again, to make the things easier to understand, of course, like we will keep it simple. So, starting about talking about lymphomas, simply lymphomas can be defined as simply these are the collection of lymphomas, collection of lymphoid malignancies in which the malignant lymphocytes accumulate at lymph nodes, okay, and lymphoid tissue. Now, when the cells they are accumulating in the lymphos, like the lymphocytes or the cells they are accumulating in the lymph nodes and lymphoid tissue, so what will happen? There will be lymph adenopathy, right? Or the short form is LAD. Lymphadenopathy will occur. Simply, the patient will say the lumps and bumps, I have many tumors, small tumors or lumps and bumps on the body. And I already told you what are the things, areas where there is lymph nodes in the body. So there will be lymphadenopathy. Also, there is extranodal. Like extranodal means what? Other than lymph nodes. Uh, Disease can be there. For example, spleen can get involved, liver can get involved, and any other organ can get involved. And the third thing is constitutional symptoms, um, or you can say the B symptoms, um, which I already talked about before, right? The weight loss thing, uh, the temperature thing, the night sweats thing, and the exertion. Okay, how this lymphomas or leukemias, uh, they are classified is again uh, there are different type of classification and staging tools are used, to classify lymphomas. One of the classification, or you can say a system which is used, okay, for staging is called as an Ann Arbor system for staging lymphomas. Okay, so basically they have like four stages: stage one, stage two, stage three, as well as stage four. Uh, there are like four stages. Okay, in this one. So stage one is basically when there is um, involvement involvement of single lymph node, okay, or you can say extra lymphatic site or organ, okay, but just one, okay, not more than one. Stage 2 is simply two or more than two lymph node, or you can say extra lymphatic site or organ, okay. That is called a stage 2, and they should be on the same side of diaphragm, okay. Stage 3 is called as, like, the lymphomas are called to be stage 3 when uh, the lymph nodes are involved on both sides of diaphragm. Diaphragm, I think you know what is diaphragm, right? So uh, no matter it is like extra lymphatic site is involved, spleen is involved, lymph nodes are involved. Simply when the lymph nodes are involved and the involvement is on the both side of diaphragm, not at one side. And stage 4 is simply uh, when there is a diffuse involvement, okay. A diffuse involvement is there of one or more than one extra lymphatic organs, okay, including bone marrow. So now the story reaches the bone marrow, so that is called a stage 4, okay. Now the subtypes, you can say, subtypes of lymphomas collectively, lymphomas, okay, are basically defined on they are called as, subtype A or subtype B. What is subtype A? When the B symptoms are absent, okay, and when it is called as subtype B, simply when the B symptoms are present, okay. So when the B symptoms are absent, it is subtype A. When the B symptoms are present, that is subtype B. As you know, what is B symptoms, right? We have already discussed that. So uh, again, different classifications are used. This Ann Arbor system for staging lymphomas can be used for both Hodgkin and non-Hodgkin lymphomas. Okay, uh, there and there are different prognostic scores, by the way, for different lymphomas. And one more thing, guys, you remember um, the aggressive lymphomas. Basically, they behave like acute leukemias. Again, what is acute leukemias? When there is too much presence of blast cells in the blood, okay, and they infiltrate the blood. They causes leukostasis or leukocytic syndromes, right? So aggressive lymphomas behave like acute leukemias. I think a very important clinical point to remember. Aggressive lymphomas behaves like acute leukemias. Okay, very important, right? So now most of the lymphomas, guys, they occur due to translocation of chromosomes between uh, two chromosomes, okay, and there are different translocations which are identified. One translocation, I think, which we already talked about, which is between the chromosome 9 and 22, uh, Philadelphia chromosome, right? So there are different type of lymphomas, like Burkitt lymphoma is there, anaplastic large cell lymphoma is there, mantle cell lymphoma is there. There is something called as MALT, MALT, or mucosa associated lymphoid tissue. So all of them, they occur due to some uh, uh, gene translocation, right? And because of that gene translocation, there is activation of some mutated genes, okay? For example, follicular lymphoma, it's a translocation between the chromosome number 14 and 18, and that basically activate a gene called as BCL2 gene, 2 activation, right? So, like this way. Anyhow, the first lymphoma which we are going to study is called as Hodgkin lymphoma. Okay, so uh, by definition, what is Hodgkin lymphoma? Uh, Hodgkin lymphoma is basically a proliferation of malignant lymphoid cells. Okay, and there is a specific type of cells which are called as Reed-Sternberg cells, which are shown over here. Okay, Reed-Sternberg cells. So what is lymphoma? Simply, I would write over here. Okay, the definition of this one, just to make it smaller. Okay, sorry, just to make it smaller, you can say, I will move it over here. Okay, so it is malignant proliferation of lymphoid cells. Okay, lymphoid cells with Reed Sternberg. This is the wrong. The spelling down is wrong. Sternberg cells. Okay, so this is Sternberg cells. Okay, so this is the definition for Hodgkin lymphomas or lymphoma. Okay, so there is one lymphoma which is called as Hodgkin lymphoma, and then there is one more lymphoma that is called as non-Hodgkin lymphoma. The only difference between Hodgkin lymphoma and non-Hodgkin lymphoma is these cells. Okay, these Reed-Sternberg cells. Okay, so simply when the Reed-Sternberg cells are present, it is called as Hodgkin lymphoma. When the Reed-Sternberg cells are absent, it is called as non-Hodgkin lymphoma. So, like most of the time, guys, this Hodgkin lymphoma, they again have a bimodal distribution. Like at 20 years of age, and later on, you can say, and later on, like more than 50 years of age. Okay, so these are the two peaks times. When the people they have having increased chances of Hodgkin lymphoma. So once like the people are around 20 years of age, they are having increased chances of having Hodgkin lymphoma, and later on, the second risk increase when the patient increases age is more than 50 years of age. Okay, so that's why it is called as bimodal distribution. And many of the times, they found like Epstein-Barr virus is associated with Hodgkin lymphoma. Actually, what I will say, like Epstein-Barr virus is associated with 50% of the cases, right? So, like they found the association in 50% of the cases, around 50% of the cases. Okay, they found like the people who have Hodgkin lymphoma, they also have the infection with Epstein-Barr virus. If you know, Epstein-Barr virus also causes a disease called as kissing disease or infectious mononucleosis. So now, if I will talk about the clinical features of Hodgkin lymphoma, sorry. Okay, this one is what we want is this one, clinical features. Okay, now in clinical features, guys, the things to remember is Hodgkin lymphoma basically present with or classically present with this is the classical presentation, painless, okay, non-tender, or you can say non-painful, firm, rubbery lymph nodes. Okay, and the most common region you will found in, you can say, in cervical region. Okay, so most of the patients, of Hodgkin lymphoma, they present with painless, non-tender, firm, and rubbery lymph nodes in cervical region. So, and one of the thing, there is a connection with alcohol. I will tell you later on. Okay, so This thing is present, is so common that up to 70% of the patients who have Hodgkin lymphoma, they present with this thing. Okay, so of course, like the patient complain of lumps or bumps, and then when you examine, your examination findings will be this one. Okay, when you will examine the, whenever we examine any mass, what we see the color, we see the surface site, we see the color, we see the consistency, we see the fluctuation, we see the fixation, we see the transillumination, we see the compressibility, uh, all these things we see, right, in the patients. Okay, so most commonly in the cervical region, they can be in supraclavicular, as well as axillary, as well as inguinal. Okay. By the way, inguinal. As you go from head to toe, the chances, like cervical is the most common, then supraclavicular around 60 to 80% of the times, axillary around, you can say, 10 to 20% of the time, inguinal, around 5 to 10% of the time they are like at this sides. Okay. Uh, they can also cause splenomegaly, or as well as hepatomegaly. Uh, Not in all the cases, but it can occur. Okay, so this is the thing, this is how they present. Uh, of course, Reed-Sternberg cells are uh, the hallmark of the condition. When you found Reed-Sternberg cells, done. It is Hodgkin lymphoma. When Reed-Sternberg cells are absent, of course, it can be non-Hodgkin. So mediastinal mass can be there. Okay, of course, mediastinal mass is most of the time is found on the chest X-ray, right? But whenever there is mediastinal mass, the patient can present with cough, as well as superior vena cava syndrome, like when the superior vena cava is compressed, guys. So there will be congestion of the face. There could be hoarseness, and there could be like, because the blood from the face is not drained properly, so there is congested face and all these things. Okay, a red big congested face can be there. There could be pleural effusion. Okay, so all these things can occur, of course, whenever there is mediastinal mass. Now, the very important thing, systemic symptoms. Okay, and now if you remember, in systemic symptoms we just see one thing, B symptoms. And based on that, we say either the patient have type A or type B. If the B symptoms are present, okay, like pruritus, like fever, it is type B. Otherwise, it is type A. So one thing which is not so common, not in all the patients, okay, but many people, they have pain in lymph nodes, okay, upon consuming alcohol. Okay, and not in all the patients, okay, but many patients, they have alcohol induced pain in the nodes, okay, as well. So now you know how the disease progress. Of course, the disease start at a single site like cervical lymph nodes, and later on it starts spreading to other parts of the body, for example to the spleen. Now see, uh, someone who have the Hodgkin lymphoma in cervical lymph nodes as well as the inguinal lymph nodes, so see, the spread is on both sides of the diaphragm, right? So that is the thing. So of course, like the disease, you can say disease spread through lymph nodes, right? Of course, like, because it is like the lymph nodes, they are all connected together. So these are the clinical features, of the patients who have Hodgkin lymphoma. And then we go for investigations uh, in these patients. And in investigations, what we do is, again, the first investigation in all the lymphomas, leukemias, it remains same, a very helpful investigation, guys. That is, of course, CBC. So in CBC, when we go for CBC in these patients, what we found, like they present with anemia. When when the disease is chronic, not in the earlier disease. We can get eosinophilia. Okay, we can get lymphopenia, and we can get even decreased platelets. But of course, in advanced disease or in late disease, okay, not like in early disease. We can do a lot of other tests, for example, or biochemistry tests, for example. Liver enzymes can be checked, okay, to check for liver involvement. You can check what you can say renal function test, or you can check alkaline phosphatase to check for bone involvement. Okay, so to check for bone involvement, you can do alkaline phosphatase. You can check calcium levels as well. Okay, you can check ESR or LDH, right? All these tests can be done in these patients. Then we can go for imaging. In imaging, I talk about the mediastinal mass, so chest X-ray is one of the tests, okay, or CT scan of the chest. Is very important. Also, you like to check for the liver involvement or spleen involvement. You can also do abdomen CT scan, okay, or even pelvic CT scan to check for all the other lymph nodes involvement. Nowadays, of course, PET scan is the newer scan which replace like many other investigations. So you can do all these things. That's right. So guys, like this, these are the tests which we do in these patients. Rest there are what you can say because for treatment, we have to provide them with chemotherapy, and before starting chemotherapy, we have to run a lot of tests. For example, this RFTs we must do before starting chemotherapy. PET scanning we must do before starting chemotherapy. You can say echocardiography is done before starting chemotherapy to check for the cardiac status, how well the heart is functioning. Okay, especially the people who are old age, like more than 60 years of age, and many of them, they have the history of hypertension, or congestive heart failure, or peripheral vascular disease, or arterial diseases, myocardial infarction, stroke, and all this one. So all this. Chemotherapeutic drugs have a lot of side effects. So of course, like due to those side effects, they can affect the heart, and they can affect the kidneys and all these things. They can affect the lungs. So pulmonary function tests can also be done before starting chemotherapy. Okay, so all these tests can be done before starting chemotherapy. Okay, this is like just to decrease the risk of any complications, before starting chemotherapy. Other tests which can be done, by which we can confirm or reach the diagnosis is, of course, lymph nodes biopsy, okay, or you can say bone marrow biopsy. Okay, so lymph node biopsy or bone marrow biopsy can be done to confirm the diagnosis, okay, and to see if the bone marrow involvement is there or not. Okay, so many of these tests, understand, like they are not there to check for the involvement or check for to make the diagnosis, but rather they are needed for baseline testing before starting chemotherapy, because all the chemotherapies have a lot of what you can say complications. Okay, so see this one, these are the investigations. You can see we are talking about. See lumbar puncture and all the things which I talk about there. You will found over here. Okay, so anyhow, these are the what you can say the investigations which are written in too much details. Anyhow, guys, the important thing to mention over here is what, other than investigations, of course, we want to talk about treatment. So in treatment, of course, like all this carcinomas, they have the treatment is simply chemotherapy, right? So staging I already talked about, right? So the treatment depends on the stage, okay? And we already talked about the staging. So if someone is at stage one or stage two, you can say, then we gave them a regime called as ABVD, okay, followed by radiotherapy, okay. Now, what is what is this ABVD? Is basically okay. What is this ABVD regime? Again, like these A, B, V, and D are basically the name of different drugs. Okay, A is for adriamycin. Okay, then B is for bleomycin, and V is for vinblastine. Okay, and D is for dacarbazine. So or procarbazine. So A is for adriamycin, B is for bleomycin, V is for vinblastine, and D is for dacarbazine. So this ABVD regime is used, okay, and anyone who is at stage 3 to stage 4, you can say, again, we give them adriamycin, bleomycin, vinblastine, and dacarbazine. Uh, okay, in this one we give radiotherapy to the site only, okay, but in this one, of course, like this is ABVD with like radiotherapy, okay, but like most more extensive type of radiotherapy can be given. So many of the patients, they respond to this therapy and the disease can be treated, but many of the people, they relapse after treatment, okay, or many of the patients, they are resistant to this therapy. Okay, they get resistant to this therapy. Okay, so what is there? There is a combination of other drugs or regimes are available. Okay, regimes are available. Okay, and they can be tried on these patients. Okay, or we can ultimately go for stem cell transplant, of course, like if the bone marrow is involved. Okay, so we can go for stem cell transplant. So the important thing is, guys, this chemotherapeutic drugs, they are many. There are many chemotherapeutic regimes. ABVD is one of them. Then there is one very famous CHOP regime. CHOP. C is for cyclophosphamide. H is for hydroxy donorubicin. Okay, that is also called as doxorubicin. Then CHO. O is for basically oncovin, which is the other name for vincristine, and P is for prednisolone. So there is CHOP regime, there is CHO double P CHOP regime, there is DICE regime, there is ISHAP regime. Like there is a lot of chemotherapeutic drugs. Okay, there is like you can say more than hundreds of chemotherapeutic therapeutic drug. Uh, Even I remember the name of few like cyclophosphamide, methotrexate, vinblastine, doxorubicin. Okay, fluorouracil, which is mostly given for GIT malignancies, and like many of them are available. So they make combination of different drugs, right, and then they give to the patient. Okay, so if one combination fails, of course they move to the other combination. So what you can say, this is like the treatment. The complications of treatment is like the chemotherapeutic drug can affect the heart, can affect the lungs, can affect the sperms. Okay, now by the way, anyone who is undergoing the treatment for cancers, uh, before giving chemotherapeutic regimes, especially when they are young, like less than 20 years of age or around 20 years of age, so they don't have children. So what is recommended to these people, like they send them to the sperm bank to donate their sperm before getting this chemotherapy. Why? Because the chemotherapy can damage their sperms, and of course then they can have a baby by the sperm banks. Okay, so all this one, they like even radiotherapy have a lot of side effects. For example, it can lead to hypothyroidism. So all this chemotherapeutic drugs, they have a lot side effects. They are cardiotoxic, they are nephrotoxic, they are neurotoxic, they are have lungs, they damage the lungs. Okay, there's many of them. They cause, for example, interstitial pneumonitis or things like this. Okay, uh, how we check the prognosis of this condition is like, there is a prognostic scoring system which is used. There is something called as Hazen-Clever adverse prognostic factor, what you can say, is also available, right, for the patients. Serum albumin levels, hemoglobin levels, serum albumin if it is less than 40 or hemoglobin less than 105, male, stage 4 disease, age more than 45, and if the WBCs are more than 1.5, or lymphocytopenia, all these things, they count in the prognostic factor, and everyone have some points, and based on that, they see like either the prognosis is good or bad. So that's all about Hodgkin lymphoma. And the other thing which we are going to cover is non-Hodgkin lymphoma. Non-Hodgkin lymphoma. Okay, so non-Hodgkin lymphoma and Hodgkin lymphoma, as I told you, the main difference is the Reed-Sternberg cells, right? So again, the definition is quite easy. This is also a malignant proliferation of lymphoid cells of progenitor or mature B or T cells. Okay, so now this one, non-Hodgkin lymphoma, guys. This one, how we classify that? Again, a lot of classification systems exist for even to classify this one. Okay, so it's up to you. Like if you want to go into the classification, if you want to see, like the WHO classification is there. Okay, then there is something called as real classification is also there. So a lot of classifications are there. So now the non-Hodgkin lymphoma can originate from B cells, can originate from T cells, or can originate from natural killer cells. Okay, so one way of the classification is simply B cell non-Hodgkin lymphoma, and then there is T cell non-Hodgkin lymphoma, right? Non-Hodgkin lymphoma is there. So B cell non-Hodgkin lymphoma, for example, this is the most common type. Okay, this is the most common type, and there are certain examples for this. I will give you diffuse large B cell lymphoma, for example, as one of the type. Okay, like I have seen one patient of this thing. Then follicular lymphoma, okay, is also example. Now follicular lymphoma, I was giving you example that this one occurs due to translocation of two chromosomes, and there is activation of some abnormal gene, of course. Burkitt lymphoma, again, it's due to translocation of what you can say two chromosomes, and there is activation of certain gene, right? And mental cell lymphoma, again, this one again occurred due to translocation of what you can say between two chromosomes, right? which lead to simply activation of some gene activation. So diffuse large cell, follicular lymphoma, for example, I was telling you, I told you like this one is like 14 and 18, right? I remember for this one because it's easy to remember, like it is a translocation between 14 and 18 chromosome, and there is activation of BCL2 gene. Burkitt's lymphoma, it's a translocation between 8 and 14 chromosome, and there is again gene activation, some gene activation, and again, like same with this thing. So, like, of course, there is activation of some type of gene. Okay. Uh, the examples for this one is anaplastic large cell lymphoma, okay, as well as you can say mycosis fungioids, fungioids. Okay, so this is one of the classification. Then what you can say, like WHO classify them on one more category. For example, there is they classify them according how they behave, like indolent, okay. Then there is aggressive. Then there is highly aggressive, okay. So like this way. So like there is what you can say this way of classifying this non-Hodgkin lymphoma is there. For example, this follicular lymphoma is an example of indolent non-Hodgkin lymphoma. Simply, like these are the patients, uh, like they are not what you can say aggressive type of lymphomas, right? Uh, so mantle cell lymphoma is also an example of this indolent one, because this one again is not an aggressive type of non-Hodgkin lymphoma. Aggressive type of lymphoma, for example, this one, diffuse large B-cell lymphoma, is an example of aggressive type of lymphoma. Or highly aggressive lymphoma, guys, one of the example for that is simply this one, Burkitt's lymphoma, right? So it is a highly, what you can say, aggressive type of lymphoma. So I will write over here Burkitt's lymphoma. Okay, so this is an example of very highly, you can say, highly aggressive lymphoma. Okay, so what is the clinical features? Clinical features of this one. Okay. Clinical features, again, there is painless lymphadenopathy. Okay, painless lymphadenopathy is there in these, what you can say, in these patients. Okay. They present with painless lymphadenopathy, and usually more than one site is involved. Okay, involved. So, and now depending on the how the what type of carcinoma the patient is having. For example, if the patient have aggressive type of lymphoma, of course, multiple sites will be involved. If the patient have indolent or like not too much aggressive, of course, like uh, like less of the sites will be involved. So, but usually you can say, usually like it presents as a widespread disease. Okay, like when the disease is almost spread in the body, um, except in aggressive lymphomas, which can be catch at early stages. Okay, uh, constitutional uh, symptoms are not so common, like unlike you can say Hodgkin lymphoma, right? And rest is the same story, guys. Anemia, thrombocytopenia, thrombocytopenia, or you can say neutropenia will be there, right? So they can lead to hepatosplenomegaly in many of the patients. Okay, so uh, this thing can be there. Rest, like, it can involve any structure, even like mesenteric involvement is there, oropharyngeal involvement is there. Okay, so it can involve any what you can say, any type of organ like GIT, like kidneys, okay, like bones, like testes. Okay, so like any type of organ can be involved simply. Okay, even CNS involvement is there, right? So especially when this non-Hodgkin lymphoma occurs in association with HIV, CNS involvement is very common. So uh, what are the investigations in these patients? Investigations in these patients is simply the first investigation is always the same. That is what you can say, the CBC. Okay, so the CBC is the first investigation. What we found is anemia, normocytic, normochromic anemia, thrombocytopenia, neutropenia, all these things will be there. And lymphoma cells can be seen. Okay, can be seen, and we can do flow cytometry. I discussed this thing before. We can do flow cytometry. You can check the uric acid levels, which can be high. LFT to check for the liver involvement. LDH to check for the disease progression. Then remember, all the cancers we do staging workup. So staging workup, how we do that? See, we had done CBC, we had done LFT, so we will go CT scan of head, chest, abdomen. Okay, we are going to do the CT scan of all the structures. Okay, and PET scanning, of course, or bone scan simply, like to check the bone involvement. So we will go for the what you can say, for the staging workup, and we will see, like, in PET scanning, simply either there is any tumor which is present in that area or not. And last but not least, how we are going to look at the tissue. So we can do lymph node biopsy. Okay, of course FNA can be done, but FNA is more usually unreliable, fine needle aspiration. So preferred is like to take out the lymph node and see it under the microscope. And bone marrow biopsy can be done as well, to check for the bone marrow involvement. So like the investigation workup is somehow more or less same in all the conditions, right? Okay, then we go for the treatment for non-Hodgkin lymphoma. So the treatment, again, depending on how the patient or how the disease is. For example, many of the patients have localized disease. Okay, many of the people, they are suffering from indolent lymphoma, very slowly spreading. Many of the patients, they are suffering from aggressive lymphoma. Many of the patients, they are suffering from highly aggressive lymphoma. Okay, so again, the treatment depends on what type of the patient is there. Okay, and what are the sites which are involved. For example, localized disease, either it's in brain, either it's in abdomen, either it's in bone, either it is in head. So what can be done is, like, radiotherapy can be done, okay, to destroy the cells of that specific site. Okay, plus we can give them chemotherapy, but like mostly radiotherapy is going to solve the problem. Okay, so or you can say surgery can be done as well. Okay, so these are the options for that. But for example, if someone have indolent disease which is very slow growing, so we will do watchful waiting. Okay, we are going to observe that patients, and we will see like how the disease is behaving, and if the disease is spreading too much, then you can go for radiotherapy for localized disease. Okay, for localized, of course, localized radiotherapy for localized disease can be done, like whenever like needed. uh, Nowadays, um, the drugs which is used for this one is bendamustine with rituximab. Okay, these are anti-CD20 monoclonal antibodies. Okay, like previously, what they used for these type of conditions is like CHOP therapy. Okay, or something called as CHOP R. I told you what is CHOP. Okay, previously. So nowadays, these are the newer drugs which can be used for these patients. Okay, aggressive disease can simply be treated by a combination of radiotherapy as well as chemotherapy, right? So the combination chemotherapy or CHOP therapy is the mainstay of the treatment. Okay, and nowadays they add one more drug with CHOP that is called as uh, rituximab. Okay, which is again anticlonal antibody is there. So basically, rituximab is for the people who have B cell lymphoma. Okay, this drug is reserved for them. Of course, an expensive drug. So of course, like we give them this CHOP regime, plus we give them radiotherapy, okay, for the involved sites. And if the CNS is involved, we can go for methotrexate. Okay, so you can say corticosteroids in if there is CNS involvement. Okay, so then we go for this thing. So and the story remains same, guys. Like if these CHOP therapy is not working, you will go for VAD or ABVD or any other. One thing is called as a very uh, you can say strong type of regime is there called BCOP, BEACOPP. So in this one, B is for bleomycin, E is for etoposide, A is for adriamycin, C is for cyclophosphamide, O is for like the other name is oncomycin, but which is the other name of vincristine, and then one P is for procarbazine and the other P is for prednisolone. So see, it is a combination of 7 drugs that is called as BCOP, BEACOPP. So like that combination can be used. When there is highly aggressive type of what you can say lymphoma is there, for example, Burkitt lymphoma is there. So there is a special or intensive what you can say uh, chemotherapy is there that is called as Codomax. Okay, like how it is written is like uh, Codox M. Okay, so wait, I will tell you Codox M. So okay, so that is basically co oh, sorry Codox dash M. Okay, so now this what is this Codox M? Like because for example Burkitt lymphoma I'm talking about. Okay, that is a very highly aggressive type of tumor. So this Codox M is again like the name given to what you can say uh, the drugs which we use, right? So for example this Codox M, the full name is R Codox M, like of course like C is for cyclophosphamide, O is for which is the other name for vincristine, D is for dacarbazine, and again O is for oncomycin, and then X is for like so on and so forth. Okay, and M is for methotrexate. So simply again like this is a combination of the drugs. Okay, like which they use to treat Burkitt lymphoma. So again, it's a chemotherapy regime, chemotherapy regime, which is used to treat very high, you can say, aggressive type of lymphomas. So this thing, this is how this thing is treated. Again, like if the CNS involvement is there, corticosteroids can be given, and so on and so forth. Okay, so the complications of this condition remain same, which is like infections can be there, autoimmune hemolytic anemia can be there, thrombocytopenia can occur, and tumor lysis syndrome can occur. All these things can occur. Uh, Guys, this non-Hodgkin lymphoma, uh, like, and oh, sorry, like before going on that, prognosis, uh, again, there is a lot of numbers or systems are available. One very famous one is called as, the International Prognostic Factor Index, but uh, a lot of things are seen in that one beyond the scope of this lecture, of course. Uh, then there is, for example, follicular lymphoma. There is one more point system which is used to see like how aggressive the condition, the disease is. Okay, so talking about the non-Hodgkin lymphomas, uh, the most common type of what you can say non-Hodgkin lymphoma is basically diffuse large B cell lymphoma. Okay, and after that, the follicular lymphoma is the second most common one, and Burkitt lymphoma is very rare. Okay, less than 1% of the patients, you will see this Burkitt lymphoma. So, uh, like the clinical features, like we all talk about that, like they are more or less the same, but like of course, like each and everyone behave in a different way. Uh, not so important, right? Okay. There is just last topic which is left, that is the plasma cell dyscrasias, but like I think like that we will do it in the next week, right? Like that topic I'm going to cover in the next week. So next week, like there will be 2 lectures for hematology and 2 lectures for some other thing. Before like finishing up this lecture, um, I can talk about okay, yes, I already talked about hyperviscosity syndrome, right? What is that? Like when the blood viscosity, or when the blood, what you can say, hyper viscosity viscosity syndrome, right? So what is this one is basically uh, when the blood viscosity is increased, like what happens, like the circulation, like the circulating blood, of course, it can cause a lot of you can say issues. For example, it can give you a headache, it can give lethargy, and when the blood flow is stopped somewhere, of course there is increased chances of what, um, thrombosis, right? So uh, whenever like there is hyperviscosity syndrome, the first presenting features is headache, vertigo, sometimes stroke. Okay, a retina can be full or overloaded with the blood. Okay, which can lead to hemorrhages and which can lead to vision problem. Bleeding problems can occur, nasal bleeds can occur, and all this one. So that is hyperviscosity syndrome. And one thing which I already talked about is the tumor lysis syndrome. I told you whenever like we start treating, especially uh, any leukemia or lymphoma, uh, when the disease is extensive, those cells, when they lyse up, when they're destroyed, they are going to uh, they are going to release all their like contents in the blood. So potassium will be released, uric acid will be released, potassium will be released, sorry, phosphate will be released. And when phosphate will be released, remember it is going to bind up with the calcium, so the calcium will be decreased. So remember, when the potassium is increased, okay, so increased potassium uh, will lead to, can lead to, not will lead to, can lead to uh, cardiac arrhythmia. Okay, and you can say increased PO4. Okay, okay. Phosphate will bind with calcium, which can lead to hypocalcemia and can cause tetany, right? So tetany can occur. Uric acid can, increased uric acid can be there. Okay, increased uric acid can be there. Okay, so and of course, like kidney injury can occur. Kidney injury can occur. So how we can prevent this condition? Prevention is by giving IV fluids, okay, or IV hydration. So this thing can be done. We can give allopurinol, of course, to decrease the uric acid level. Resburicase is also a drug which reduces uric acid what you can say levels, and also treat any metabolic what you can say abnormalities. Okay. Plus, we can put the patient on dialysis. Of course, like dialysis is the fastest way, but it have its own pros and cons simply. Okay, so tumor lysis syndrome, that is called as tumor lysis syndrome. So that's it. By the way, we always talk about what you can say. Okay, I think like we are going to finish this lecture here, because what is left is the plasma cell dyscrasias. Like we are going to in that one, the most important one is multiple myeloma. So in the next lecture, we are going to talk about multiple myeloma, MGUS, as well as Waldenstrom macroglobulinemia. Okay, so one lecture will be about that, and then we will talk about what you can say the blood products. Okay, so thank you so much, guys, for listening.